Good afternoon. Welcome, everybody. We're going to give it a couple minutes so we can make sure that everyone can join. So we'll probably start here in about 2 minutes. Hey, everybody, I know we have people coming in. So we're just giving it one more minute and then we're going to go ahead and get started. All right, I said we get started. Everyone, welcome. Welcome to our webinar series, My Learning webinar. This is our third one we've done this year. We're doing quarterly webinars, which we're super excited to have you, and thank you for joining us. This presentation is actually going to be really fun. It's how benefits are priced. So I hope you guys enjoy it. My name is Brittany Buck. I'm a lead HR consultant out of our Austin, Texas office. And Erin, if you wouldn't mind popping over to that next slide where I can formally introduce. Well, actually, let me start with this one, housekeeping. As far as housekeeping goes, we do have a chat feature that you can ask questions, and we have myself and Cassie that will be able to address any questions, and we'll of course address any questions towards the end if you guys have any, as well as some of the questions that were outlined when you first registered. So thank you for providing questions. So we want to make it as interactive as possible as far as getting those burning questions answered, but there is a toolbar that you'll see at the top where you can react, raise your hand. There is a handout as well. So in that handout feature, you'll be able to download one of our benefit flyers. And then there is, of course, at the bottom, a reactions toolbar. So if you want to heart something that someone says within this presentation, you're absolutely welcome to do so. All right, so without further ado, I will introduce our presenter today. His name is Aaron Pratt. I have been lucky enough to be working with him now for a little over 10 years, so I'm super excited that he joined Employer Flexible back in 2022. He is very knowledgeable with benefits. He's actually our vice president of benefits, and he's been in the employee benefits field for almost 25 years or over 25 years. And he's really been focused on benefits related to PEOs. So he's a great expert for the last really 13 years in the PEO industry. He even owned his own employee benefits agency for about 9 years that was acquired by Texas Bank. And we're just excited for him to join us on our webinar series and really talk through insurance. And we also have our facilitator. You may recognize her from the last webinar if you joined. Her name is Cassie Wilson. She's our director of HR consulting, and she also sits in Austin. So we're super happy to have you. And Aaron, take it away.
All right. Hey, guys. Nothing better than talking about health insurance for a few minutes on a Thursday afternoon. And I'm going to start just to give you a context. Some of you know me. I will playfully say that I've got to guard against myself because my nature is I love to explain, I love to teach, and today we want to get through some really important base level content. So I'm going to have to block and tackle against myself to try to stay high level, but please know, be glad to go deep in the time of Q&A at the end on specific questions, and follow up afterwards. Be glad to engage with anyone who would like to go a lot deeper. There is so much that we could talk about. So God willing, we'll be able to stay on track today. And before I go through the quick agenda and kick into gear here, I'm going to ask what I'll call a thoughtful but rhetorical question since you can't really answer. Does anybody have any idea of how you would gauge a successful meeting? What's the main gauge of a successful meeting where you talk about health insurance? And I'll pause 5 seconds. I can only imagine the answers because I get them when I do this in front of our clients and employees. The answer is really when no one falls asleep, because this is boring stuff, right? But the truth be told, it's boring until we need it, right? So, and as soon as we need it, boy, we sure wish we'd paid attention. So this today is not about the end user and about the insured at the back end. Today is really about us as employers as we look at the obligation, and sometimes we look at it as the plight of purchasing group health insurance, right? How it works. And I hope today that when we finish, you'll walk away from it probably with some overlap things that many of you know, but hopefully some new nuggets as we go behind the curtains. That's what our first slide show, and look at really how it works. It's a lot more objective than folks know. So here's our agenda. What to remember. We're going to talk about that right at the beginning. We're going to review just quickly some insurance terminology only related to what's in these slides. Some of the terminology won't be elaborated on a lot, but we would never like slides to come up that don't have an association with the term, because there's a lot of industry terms and acronyms that get thrown around and we forget the listener doesn't know them. The science of health insurance pricing. Man, it is a lot more scientific and mathematical and objective than people think. We're going to talk about that in specifics. The PEO health insurance solution. Obviously, the team in front of you is part of a PEO, Texas-based PEO, but we operate in 5 states and we have clients and employees in all 50 states. So in short, there is a unique solution there. We're going to touch on that today. We'd be remiss if we didn't. And then knowing which pool to dip into, that'll make a lot more sense in a few minutes when we wrap up. And then we'll certainly make time for Q&A as long as this old man doesn't talk too much. So there we go. But that's why Brittany and Cassie are on the line. They're there to keep me and hold me accountable. There you go. So key points to remember, right? This is where we're going to start. This is where we're going to finish. Medical insurance pricing has a clear methodology. We're going to show this to you. We're going to talk through it, okay? Your benefit strategy should be reviewed with each season of business. What is a season? What does that mean? We're going to talk about it. You will be equipped. Well, this is funny because I'm talking about holding me, an advisor, accountable, right? But whoever that advisor is, right, you should be more equipped to hold them accountable to what they are doing on your behalf. And hopefully that's encouraging to you guys. So this isn't just about employer flexible. This is about you, the buyer, becoming a little bit more equipped. Okay, hopefully a lot more equipped. Okay. All right, terminology, real quick. Experience. You hear the words in our industry: experiencing rated, underwritten risk. You hear stuff like that. Really, those are all aspects of underwriters, these really wise, smart underwriters and actuaries, and how they assemble and manage the pooling aspects of an insurance pool. And today, we're not just talking about all insurance, we're really talking about health insurance, okay? You're going to see terms on some of the slides. ACR, that stands for Adjusted Community Rating. It's a form of pooling for small employers. Medical loss ratio. That's really the premium that comes in the door to the pool versus the claims that go out the door to the pool, right? There's a simple thing that's important. A pool needs to be collecting enough premium to pay the claims. So the premiums have to be just a smidge even or higher than the claims going out the door. Not real magical, right? ACA, probably a term we've all heard over the years. It's had many, many different acronyms that have morphed down to really pretty simply Affordable Care Act, the Affordable Care Act. Patient Protection Affordable Care Act, that's where it started. Some people refer to it as Obamacare. Some people refer to it as healthcare reform. They're all different variations of the same exact meaning of the Affordable Care Act, okay? ACA. ALE, that's a term that came around in 2010 and then went into full manifestation in 2014 along with the Affordable Care Act, applicable large employer. Probably won't spend a lot of time on that today. but the term is on one of our slides. And finally, SIC code. It's just a code, a 4-digit code that recognizes the industry that somebody in. Not a lot of time's going to be spent on that today, but you're going to see it on the slides. So I wanted you to know it's an industry code. A lot of you employers are familiar with what it implies. Okay, moving on. ACA. Man, what was the intent of the Affordable Care Act? Well, let's look at it. Okay, and there's probably 17 other bullet points we could give you, but we tried to trim this down to really the intent at the core. Okay, real intent was create a system, a set of rules that would make sure all Americans are insured. That was the intent when this was being talked about. Okay. Secondly, ensure that availability for individual health care plans, regardless of risk, was available to all Americans. That did happen. Okay. Remember, I'm talking about available. We didn't talk about affordable. Okay. So we're not going to get into that too deep, but that was another core intent of the Affordable Care Act. Okay. Create equitable insurance buying power for small businesses. Small businesses aren't bringing as much premium to the table, right? A little more volatility in the history and background of a small employer buying insurance and trying to afford it in the side of their smaller company and smaller operation. And then finally, to establish compliant large group plans. This could actually say all plans that are compliant with the Affordable Care Act baseline standards of what needs to be covered and what doesn't. It really is compliant and uniform across all plans, from the individual market to the small group market to the large group market. So the intent was to normalize what's covered, what's expected to be covered across all compliant plan designs. Okay, let's move on. Like this statement, we tried to come up with a word that would identify it. What is a compass? A compass is, your guidance feature, right? ACA is really a set of rules that declared, and I hate reading slides, but this one kind of deserves it to make sure the point's there, that declares normalized standards for all plan designs, whether large or small, ensuring every plan covers the same things for each end user. Of course, it's redundant because I just spoke to that on the previous slide, but we thought we'd put that in there just to make the impact it needs to have, okay? The baseline fundamentals don't change. There is a perception that they do, that large companies have a different buying power for a different set of plans. It's not at its fundamental baseline true. All right, boy, buying perspective, right? I'm a buyer as well. I'm a buyer of many things, just like you guys are, right, in the needs of our lives. What is the perspective of buyers around health insurance, right? Well, let me show you a perception that we run into every day with clients, and I'm sure you felt the same way. It's subjective. Feels like I'm buying a used car. Feels like my agent, my advisor is full of smoke and mirrors. All right, well, I'm not trying to advocate for the craft of goofy insurance brokers who peddle health insurance, but it's not really quite as it seems, okay? So it's actually very scientific, and it's a lot more precise than people realize. So now we're to the spirit of today's call, right? This is what this meeting is about, is really to go over some of those baseline fundamentals, not go too terribly deep. We'll save that for you and your advisors, or you and us, and during Q&A, and then follow up if we have a chance to speak with you, okay? So that's what we're targeting. So premium configuration. Where do our health insurance premiums come from? How are they assembled? Are they just coming out of the thin air? No, they're not. So what is an allowable, compliant, legislated allowable factor number one that is the baseline for where our initial premiums come from? Magic, age, right? What is unique about age, and why is it allowed to be a differentiator in my rates versus Brittany's rate, right? Brittany's 21, I'm 79, right? We're different, right? She's not that young, and I'm not that old, for the record. Okay, but I'm sorry, Brittany. The age is a simple determiner. If you look at large numbers, younger folks are going to use less care. There are anomalies, people born with conditions that develop certainly conditions and chronic issues, but in the whole, we're going to consume much less of the healthcare needs of our lives when we're younger. And as we age and drive closer to the end, we're going to begin to use more as our bodies begin to fail us, unfortunately. So it is allowable, it is scientific, it is measurable. That's a key foundation in rates. Zip code. Boy, this brings a lot of confusion to folks, right? Why does my zip code matter? Well, please understand it's not about what neighborhood I live in. I live in the greater Austin, Central Texas area. I don't know how many zip codes there are, but there's a ton. Zip codes is really an identifier of a core set of community zip codes around bigger, what we would call metropolises. So if you picture Texas, most of you on this call are probably Texans, but if you're not, you're from Oklahoma, Montana, somewhere else, that's fine. Just picture the bigger cities and the counties around those bigger cities where the carrier has a certain amount of predictability that if somebody in any one of these greater wide community zip codes gets chronically ill, gets into large problems and conditions, where are they most likely going to end up for major care? At the major hospital systems of the big city. Okay, so if you picture Texas, the greater Austin area, the greater Dallas and Fort Worth area, the greater San Antonio and the wide counties around that, where people in those areas are going to travel into the major city and the hospital systems and clinics and caregivers there for their major care. So just wanted you to know zip code matters, and we'll expand on that a little bit further in a few minutes, okay, to be more precise. Medical inflation, right? We're going to spend some time on medical inflation. In fact, I'm going to stop right here and give you a definition of it that you might not have heard before. If you've had an insurance renewal, for sure, someone has mentioned part of your increase or part of your change of rates was driven by the rising cost of medical inflation. What does that mean? Well, it's not near as abstract as it's not explained enough in our humble opinion. So I'm going to attempt to do that in some real quick cliff notes for you right now. Okay. There are some very positive aspects to medical inflation. Okay. Put aside the negative that inflation means increase. The positive is this: new procedures are being invented all the time. New prescriptions that actually sustain life and restore health are being invented all the time, right? New legislation is being passed that forces the health insurance industry to cover things that they didn't have to before because legislators have found it necessary to invoke legislation that says it must be covered. So if it wasn't covered on my last renewal in my last year's policy, but now the legislation was passed, there it is. And the pool has to get ready to absorb those changes and influxes, we'll call it, in responsibility or burden to pay claims, right? So if you picture just a couple of those points, medical inflation has some positive. Things are actually being covered that weren't before because the greater overseers, the American Medical Association, the Food and Drug Administration, which oversees the industry, has found it, has deemed it ready for public consumption. That new procedure that was invented, that new drug, right? That new legislative order commands it in there. And that causes a new burden financial to the insurance pool, and they have to prepare to pay those claims now. Okay. Negative inflation is probably a more subtle, smaller part of it is, but in simple terms, the inflating dollar or the shrinking value of the dollar is certainly impacting here. So, our economy requires that cost of goods, and by the way, medical care is a good, so to speak. If it's going up in cost to pay the provider, the insurance carrier has to also increase its rates to prepare to pay those higher costs that they're paying the providers. So there is your quick snapshot of medical inflation. Medical inflation is not a piece of the puzzle that can be avoided by anyone. In fact, I'll finish with this. Legislative statutes require this, and this is strictly overseen and monitored by the Department of Insurance, that if a carrier and the pool that you're in, so if I'm buying from a certain carrier in Central Texas, I'm in their Central Texas pool. If that carrier needs an extra, I'll pull out a number 8% to bolster up their pool to counteract the new inflation rate from a year ago. Then every single client participant in that pool, when they get their renewal, will receive as part of their factor an 8% increase. And they can't change it, alter it, remove it from one versus another. It has to be evenly spread. So why aren't all renewals uniform to inflation? It's because the other two factors, and there's a fourth factor in some pools that are in play as well. So let's go to the next slide, right? We won't have to go as deep here because most of it's redundant, right? Premium configuration in other plans. So let me go back up here real quick. This is for small group community rated plans. I forgot to mention that. So this is community rated plans or communalized risk-based plans. And we're going to touch on that deeper in a few minutes. That's why I didn't remember to state that on this slide. And then you've got plans that are subject, they're all the other types of pools, all the other markets that are allowed to medically underwrite and review your experience. So the foundational rates are still going to be in these pools predicated on the age of the participants or the average age. The zip codes where those participants live are going to play the same role in both types of pools. Then they're allowed to, in these other type of pools, to analyze the risk of each pool participant, and in other terms, identify what risk exists in that population that's different from the average or the norm, and either add additional rates because the risk is adverse, or actually lower the rates if they're bringing less risk than the pool average participants are to the table. That's called pool risk distribution ratios. That's called experience rating. You can call it underwriting. It's pricing based on that client's buying into the pool's actual experience they're bringing to the table. And then finally, medical inflation is always going to be part of it. So in short, doesn't matter what pool you're in, factors 1, factors 2, and factors 3 are the baseline for how the carrier is assembling their prices. And then any pool that has the right to underwrite, medically assess risk, has the right to assess and adjust our premiums based on that other factor, right? So thought we'd throw this in here. I think there's a poll coming right now, but zip code predictability. All right. What percentage of participants drive 80% of our pool's payouts? Picture a pool full of insured people. What percentage of all those people in the pool, by law of large numbers, spend 80% of the money in the pool, meaning cause 80% of the payouts?
Give it another second here. Looks like we're all over the board there, Aaron.
Okay, did we come up with an average? We did or we didn't?
Show it to them.
Huh? Show it to them. This is the approximate average. All right. And I saw a lot of numbers hovering on the under and the over side of that, right? You could look up the statistic and probably find it in different numbers than 15%, but it's going to be, all of it's going to be right around there. The general principle that this is trying to pass on to you is pretty simple and straightforward. We are insuring our risk. We're not financing our risk. So the majority of us, when we are sending in our insurance premiums, aren't consuming equivalent dollars to the insurance premiums we're sending in. But the majority of our insurance premium dollars are propping up and paying for those folks who are unfortunately in tough situations. That's the point of it. And we can't forget that when we're shopping and buying and pricing our insurance, right? When you're participating in a pool, there are going to be seasons where if you're trying to do an analysis of dollar for dollar in, dollar out, it's not going to measure up. And there are going to be seasons when it really measures up way in your favor because your dollars in versus what was paid out is way upside down because you've had some less fortunate folks. But at the core of it, that's why we need insurance, right? Because it's impossible to finance it ourselves, okay? With the exception of a few people that are million and billionaires, okay? But even they insure because they don't want to waste their money, right? So zip codes help. We've tried to tie this together with zip codes. Why does it matter? Your employees and your company is based in certain zip code or blended zip codes. And this allows the carrier to predict the cost of those most major claims and where they're going to occur and be incurred. And therefore they can get the pricing built around where it's most likely people will consume major claims, right? Most people consume their major claims around where they live. We don't travel other places to consume our claims when we're really sick, Okay, so that's where the predictor comes from. All right, let's look at the scientific side of pricing. Okay, we've touched on it. Now we're going to dip into before the Affordable Care Act was passed. So in December of 2013 and prior, so January of 2014 is when the Affordable Care Act was passed. A lot of people don't realize this, but some of the core tenets of the Affordable Care Act actually went into play and were imposed on the industry September 23rd of 2010. And then there was a season where those were inlaid, and then the full impact didn't actually land in the market until January 1st of 2014. So what did the industry look like? What changed? Let's look at it. And this will also illuminate some of how pricing works in the health insurance pooling industry. Okay, so let's first look at small companies. So before the Affordable Care Act, a small employer was an employer that had between 2 and 50 employees on payroll. Notice I didn't say full-time employees, part-time employees. This is employees on payroll. Health insurance and employee benefits, by large part, are only available and only required to be made available to our full-time employees. Okay, so I'm distinguishing that little piece. But the amount of employees on payroll is the driver of what causes a carrier to have to treat you as a small business. So before the Affordable Care Act, what were some of the foundational factors that they were using scientifically to try to assess your rates as a small employer versus your neighbors? Well, your age was in there, still is today. Gender, right? Some of you might say that sounds discriminatory. All we're talking about is the scientific or the math part of it on how genders consume healthcare differently. That's all we're talking about. And the industry use that scientifically in the rates. Zip codes, that's still in there. It was in there yesterday, implies the same thing. SIC code, so what industry you were in as a buying company was allowed to be differentiator in your rates. Okay, some industries are higher risk by nature, and by the nature of what folks do in that kind of company implies that they're a little bit higher risk to the insurance pool. So that was a factor. And finally, this is overblown, and a lot of people see this as much more important than it is. It never was as big of a deal as people thought, but the employee count. How many people are buying? If I have a bigger company, I'm going to get better rates. If I have a smaller company, they're going to be worse just because I'm not bringing as many people and much buying power. It's not true. There was a little differentiator allowed, but it was never as profound as folks think. Okay. And so let's just look at who's in our workforce. In our workforce today, the majority of folks working full-time are between 20 and 64. There are folks not on their parents' plans anymore. They're standalone that are under 20. But in the pricing world of premiums, the carriers treat 20-year-olds and any adult under that who's on a plan on their own as about the same price or the same risk. There are folks over 65 years old still full-time in the workforce inside of our premiums, inside of our pools, inside of our companies. But there is oftentimes some sharing with Medicare, so the pool aspect of how those rates are assembled are a little bit different. So for today, just think about the matrix of the folks in our workforce from 20 to 64 years old. This is an average, okay? But the differential in the way scientifically we consume healthcare dollars, if you think about a sloped graph from a 20-year-old at the very bottom, from a risk standpoint or a consumption standpoint, to the 64-year-old at the very top of this continuum, science would say that we consume about 1 to 8, or if you go the reverse, 8 to 1, the older versus the younger, in the actual claims or medical care we're going to consume. And so the carriers would, when you brought them a census and they averaged your premiums together, this continuum, this slope, would be how they'd add up everybody's rates behind the scene associated with each person's age, add them all together, and divide by the average to come up with your average rate. One last thing I'll say on that, if you think about usage, going from 20 to 21 to 22 probably doesn't change usage much. If you're looking at a graph, you would see a slope where probably from 20 to 30, it begins to creep upward. From 30 to 40, a little bit more of a creep. Then it starts to move a little higher, quicker, 40 to 50 and 50 to 64. The bell curve's going to jump, right? So it's not just a perfect stair step. And then finally, what would they do? They were allowed to underwrite the risk of a group. A lot of people think that folks could just be arbitrarily turned down as a small buyer before healthcare reform. Well, in the 25 years I've been in this business, that wasn't the case. There was actually a cap of 67% above the core factors of your age, gender, zip code, SIC, and employee count that they could tack on if they found that your population was ridden with adverse risk. That was going to be a really poor equation to invite you into the pool. But if you wanted to buy in that pool, they had to take you, and the most they could inflate your premiums above the average was 67%. They couldn't decline you. 67% is a lot above zero if you were the healthiest group, but I think you get my point, right? So we would call this partial community average, right? And just remember, they couldn't decline to offer you premium. So what was the formula? The formula of assembling rates was your demographics, that's what's in gray at the top, plus an assessment of your actual risk, actual buffered to a cap, of course, became your rate or your premium, okay? Now let's look at large group. Real quickly, I'll go a little bit quicker here since the slide looks similar. Large group used the same 5 criteria. It's kind of the same core workforce by age. The science probably delivered the same thing. The difference for large employers is they're seen to have a lot more buying power. So there was no rule that says if I wanted to buy from a certain carrier into a certain pool with a carrier, that they had to take me. So they could assess my rates. They could make me an offer, they could decline to offer, or they can offer me anything in between, right? So the bottom line that's different, and it still is the rule today, is that large employers are in a marketplace that can look at them, assess them, offer them a rate, be more aggressive than what they give their neighbors, less aggressive, or even turn them down for an offer, okay? So that's before the Affordable Care Act, kind of how the two markets looked in a real general sense. What happened after the healthcare reform market was put in place? Well, let's start by looking at a couple of things. Small group is defined as a company with employees between 1 and 50 employees. So literally an employer that only has one W-2 employee could buy insurance. You didn't have to have a minimum of 2, and you could still get a group policy. Medical loss ratios were laid in. That means the pool. If you picture these community pools and you picture a single carrier, pick the carrier name and add it into the pool over Central Texas. For every dollar they collect in premium, as of January of 2014, if it's a small employer pool being managed with small employers collectively in that pool, they have to spend 80 cents on the dollar on a claim, and they only were allowed to use 20% of that premium collected revenue to run the pool, run the business, okay? It became more stringent. These came into medical loss ratio law for large employers. So those large employer pools had to be run more lean. So the premium that was put together by the actuaries, 85 cents on every dollar, even to this day, has to be spent on claims, and the pool has to be operated and run. The insurance company has to run the entire business on the 15% portion of the collectible premium to the pool. All right. So glancing at what changed, this is pretty specific. Let me ask for a second. How are we doing on time, guys? Seem to be okay? All right. So again, I'm not going to be too redundant on the stuff that's common, but I want to take your attention to the gray at the top. A couple of things that healthcare reform law enforced and changed about how the small group pool had to be assembled, okay? And the adjusted community rating rule, that's that ACR rule I said in our terms, right? Here's what changed. They could still use the age and the zip code as core foundational scientific math equation factors in assembling premiums, but gender and the industry or SIC code and the number of employees buying, whether you're a group of 1 or a group of 50 on the button, you could not differentiate for these factors at all. Everything on those other factors had to be averaged to the middle, okay? So that's a pretty significant change that actually normalized across industry, group size, right? And gender, the buying situation for the employer, okay? Still 20 to 64, that's our core full-time working public in the United States, but look at the change in the differential ratio. In other words, the Affordable Care Act says we want to normalize the volatility of the small buyer and not allow the younger people to get the younger companies with younger audiences to have super deflated rates, so to speak, compared to the older audiences. We need to normalize that and bring some fairness. Okay. So in short, the youngest person, or you could say it the opposite way, the oldest person in the census pool rates, right? That 64-year-old could be no greater than 3 times the premium of the 20-year-old. Instead of letting science, which is about an 8-to-1 principle, drive how they priced, they sandwiched it. So here's what I want you to hear on that. If you picture January 1st of 2014 versus a quote run on December 31st of 2013, and we ran the same census, right? The youngsters on the census and their impact of savings in December versus January was demonstrably different. So the rates for younger folks went up quite a bit to buffer the rates of the older folks that went down, we'll call it a decent amount, but if you look at the proportionality, it basically sandwiched the premiums. And it caused us to really begin to, ideology put aside, the youngsters began to subsidize the oldsters, and the oldsters began to be able to be in a more normalized pool. And then the final thing that was required by the Affordable Care Act, or these adjusted community rates, is no longer could the carrier in this type of pool underwrite your risk, ask you even any questions about it. They couldn't turn you down still, and they couldn't exaggerate or adjust your rates if you were bringing adverse risks to the table. So every single pool participant in a community rated plan or adjusted community rated plan using the full acronym is going to have a equal percentage share tied on top of their age and zip code baseline score and be sharing equally in the risk of every other participant in the community pool that you're in. Okay. What did that do for the buyer? Well, it normalized the buyer. The riskiest groups that were paying inflated premiums compared to their neighbors now were normalized. The folks that were the healthiest and the lowest utilizers were brought up to begin to subsidize and balance so that the small business buyer with less premium to the table had less volatility in their buying, and it normalized the experience. Okay. So hopefully what you take away from that is this is compressed demographics. So they've compressed it to a 3-to-1 principle, right? They've added community risk as a mandate, right? If you're the healthiest or the sickest, you get to be invited in. If your average age as a sick company is the exact same as the average age that's a small, not sick company right next to you, and you buy the same health plan, your rates are going to be the same. You're sharing, okay? That's your premium. So that's how it changed in small group. There was a lot of things passed. Can't go deep in this today, so I'll keep moving. But large group plus this new market called level funded you've heard of, which is really small groups being underwritten like large groups, put together to try to circumvent the Affordable Care Act community rating pooling, which is fine. We won't go deep into that. Level funded for small groups, large groups, self-funded, all of that is underwritten. That's the only thing I want you to take away is it's experience rated. They still use the same factors, but they are back into the world of before healthcare reform, because healthcare reform really didn't impact the factors, the scientific factors that were buried in how the health insurance risk, health insurance premium is assembled. So those pools have basically bypassed community rating pools mandates to allow the buyer to possibly buy insurance for a little bit less than the community average rate of a community pool, especially the small employer buyer. Large employers are still in a buying pool that can underwrite you, accept you, make you an offer of any rate that they think you'll accept, or decline to offer if they don't like your risk. Okay. And that applies to all of these different types of pools at the top. So demographics plus your actual risk equals your rates / premiums. Should have put on here, or your declination to be offered. Okay. So moving on, PEO master policy advantages. What are the advantages here? Well, if you are blessed enough to be a partner with a PEO, especially with employer flexible, please play along with me. We have a master policy. So we have an insurance policy with a major carrier. It's a large group policy, and not all, but probably 70% of our clients have participation in our master policy on the health insurance, right? And they get to participate in the tenets of a large group pool. I'll touch on what that means in a minute. Economies of scale. When purchasing many employee benefits products, there is a piece of it that's economies of scale. I want to buffer this little statement a little bit. Economies of scale with buying better health insurance premiums is not as wide and deep and as favorable as people think, but it does have some favor. I want to touch on that, okay? Real rates, not subject to community rating. Real is probably not the perfect word here, but it's rates that are assessed based on your favor or your lack of favor. So it's really a more true to your who you are and the profile of the risk you're bringing to the table. Okay. Sometimes in an experience rated pool, you don't want to be in that pool if your rate's really ugly. That's when the community pool and you're a small employer begins to be your best safety net. We'll talk about that, touch more in a second. Ability to reward small companies with true demographic premised rates. Smaller companies can be rewarded with preferred rates when evaluations show that they're a slightly younger demographic, or they have a low health risk basis when their experience is discovered, right? So some of these are obvious, and I'm going to go fast for the sake of time. Low utilization can actually result in helping you keep your premiums less than the community pool average, where all the risk is averaged to the center. Ability to use a small group community rated market if one's risk becomes adverse. Please, this is a key buying point for us as small employers, right? Not everybody on this call is a small employer, but if you're less than 50 employees and your risk becomes terribly adverse, you can't control folks that get sick, dependents that get sick in your population of insureds. The community pool is there as a safety net to keep the carrier from being able to exponentially increase your rates and run you out of the market. So we use that very strategically in the community of insurance advisors. Full compliance management of all your ACA tracking, reporting, regulatory issues related to employee benefits management, and more. Why did I read that? Because ACA is arduous related to compliance, okay? For those employers who have touched in that, you know what I'm talking about. 6056 reporting, 1094, 995Cs, all those different things we have to do to track, right? That's all uniform and tied in and done on your behalf inside of a PEO master policy. Easily plug into an existing policy. It's an active policy. You're not buying a new policy. You're plugging in as employees. Yes, you have your own chosen plans and premiums inside of that, but you're joining an active policy. So the administration, the entry and the departure at times when you need to depart is a lot more simplified, okay? So what's the key to our successful benefit strategy? Knowing the difference between available markets and reviewing them during your renewal season, right? And what I hope you took away from this is pretty straightforward, right? There is not as many pools as you might think. If we reviewed them quickly, all of us have access to the individual pool. We don't have to take the insurance through our employer, but it behooves most of us to do so because it's a richer, slightly richer benefit, easier to navigate. The employer's paying some of the premium. That's in our favor. So the individual market's mostly used by self-employed people or people that work for employers that don't offer health insurance, right? Then there's the small group pool of community rating. Then there's a small group pool of level funding. Then there's a large group PEO pools, large group self-funded, large group level funded. I'll refer to all those pools, large group pools, as experience rated using the same core tenets. They're measuring your age and your zip code and where you're going to access your care, and then they're underwriting you. In the community pool, they are actually using your age and your zip code, and they're not eligible to underwrite you. They're averaging you to the risk of the pool, right? So know which pool to dip into. I think I've gotten right by a pool. Sorry, guys, but did I miss one in there? No.
Yep,
All right.
you're all good. We'll test
So
their
small.
knowledge in a bit.
All right, we'll test you at the end. Summary of options. So let's just do a quick review. Again, so much more we could say, guys, but we have to keep this to the high level points, and maybe we'll do a follow-up and we go deeper on another webinar. Small group pool, what do we have? We have adjusted community rating pools, right? have to take you, and you're paying the same rates as your neighbors based on your average age and zip codes, okay, regardless of your risk. We have small group level funded pools. So that's you as a small group being able to go into a different pool, maybe even with the same carrier, but a separate pool that doesn't have to adhere to the tenets of community rating and the Affordable Care Act. By the way, level funded is a mini word for self-funding. Self-funding was written into the Affordable Care Act as not or being able to avoid these tenets. So the carriers developed these level funded small group pools and wrote those with the states that they chose to organize pools that would allow underwriting for small groups. Then there's the large group PEO master policies that are available for small employers, where you can gain the economies of scale. I want to say this, you can gain medical loss ratio advantages. Large group pools have to run their pricing more lean than small group pools. They have to spend 85 cents on the dollar versus 80 cents. That means you have about a 5% buying advantage even before they start doing the math on your age, your gender, and such. Okay, age and zip code. Large group has not fundamentally changed very much. It's experience rated. That means it's underwritten. They get to scrutinize your risk. They get to analyze who you are, decide to invite you, decide not to invite you, or anywhere in between. Okay. And then for large groups in the PEO experience rated pool, you have access to a secondary pool for larger employers. A lot of commonality between how the underwriting is done, but what you gain is administrative and continuity, administrative advantages and continuity advantages related to how it's managed, how the tenets of compliance are handled. And so the differences are more subtle, but they are for sure relevant. Okay. So what do we want you to remember? Redundant slide here. Medical insurance pricing has a clear methodology. I hope one of your takeaways today is it's a lot more scientific than it might have felt over the years. Okay. And if your advisor is showing you the difference in the pools based on the size of you as an employer, how many employees you have on payroll, you should be able to see very clearly, very quickly the pool that best fits for you if you're being taken through that puzzle correctly. Okay. Your benefit strategy should be reviewed with each season of business. By the way, guys, there are seasons when things don't change too much. You're risky yesterday and you're risky tomorrow. The small group pool is where you should stay, right? So it becomes a little less complicated. But when things change, when your risk profile adjusts, that's when you want to become more creative, right? With a PEO, you have that creativity going on all the time. We handle clients inside and outside of the community pool and the large group plans. And you'll be equipped to hold your advisor accountable. Isn't that what we always want to do? Be able to tell them how smart we are and prove to them that we're smarter than they are. That was the goal. I'm kidding, of course. So, God willing, this actually has really illuminated some of the really core things that have always felt mysterious or maybe mystical, whatever you want to call it, and illuminated that it's a lot more scientific than people think or what we've perceived. Okay. So, what is the correct way to view health insurance moving forward? Here's where we finish. You are not financing your medical care. Don't let yourself fall into the trap of thinking, I had a little bit better medical loss ratio this year. Don't I deserve a big decrease? When you're running well, be thankful that you're only subject to medical inflation adjustments in your pricing, right? Because you're not one of the folks who's having a season of problems with our health issues with the folks in our company, right? But we all have to be able to, in our pools, help prop up and make sure that the pool stays solvent so it's there when we need it, right? You're insuring your medical care. You're not financing it. I really, really pray this helps. I'm sorry if it was a little bit boring at times. Let's test your knowledge.
Awesome. Thank you so much, Aaron. Okay, so we'll ask you guys a few questions here just to see how much of Aaron's conversation stuck with us. And then we also want to give you the opportunity to ask an expert anything and all things benefits. So several of you actually threw in some questions for us beforehand. So I'll pop those over to Erin in a moment. But as we're testing your knowledge, then over a couple polls here, if you want to start thinking about some questions, you can use that Q&A feature up at the top right-hand side of your menu bar and ask away, and we'll be sure to get Erin's insight on that. If we don't have time to get to everyone's questions, Erin will certainly address them after the fact as well. We can reach out to you separately. So, okay, let's see how we did here. What 3 things contribute to the cost of small group community rated plans? We'll give you about 15 seconds here, and then we'll close it out and see how we did. So far, looking unanimous. We got a little bit. Okay. Good job, guys. Yes, age, gender, and zip code. So the trick question there was the small group, right? So utilization does not come into play for those small group community rated plans. Okay. Let's see here. Which of the following is not included as an advantage of being on a PEO master policy? Got large company underwriting, economies of scale, real rates not subject to community rating, you're included in the pool and your utilization does not impact your rates. Give you guys about 15 more seconds here. Still going, and we've got about 5 seconds left before we close it down. Okay, let's see where everyone went. We're a little all over the board, but it looks like most of you guys said you're included in the pool. Utilization does not impact rates. Correct. That is the one that is not an advantage of being on a master plan.
That's a tricky double negative question, Cassie.
Another trick question. See, that's how I like to do it. How many employees do you have to be considered a small group? This one's a little tricky too. Is it 15 or less, 25 or less than 50, or 50 or less?
I don't see the poll. There it is.
And we'll give you about 20 seconds here.
That's another trick question. That's mean, Cassie.
I know. This is a tough one, guys. Okay, we're going to end and share results. Looks like still the majority of folks picked 50 or less, which is the correct.
I say we got to give it to the 28% as well, because that's mean.
Okay, and then, you know, at the very end and in the beginning, we asked kind of main points to take away. So what was not included as one of those key takeaways that Erin wanted us to remember? Is it medical insurance pricing has a clear methodology? Is it that benefits renewals should stress you out? Is it that your benefit strategy should be reviewed each season of business, or that you should be equipped to hold any insurance advisor accountable? See, I throw in an easy one here and there too. We'll give you 10 more seconds here. Okay, yes, benefits renewal should stress you out is not the key takeaway that Erin wanted us to know about. Okay, so as far as questions go, looks like we may have another one coming in here. Please feel free to throw into the Q&A or reach out to us afterwards. But we did have a lot of great questions come in prior to the webinar, and we'll try to get to as many of those as we can. So Erin, if you don't mind kind of helping us through some questions here that came in. One person asked, I'm asked a lot about the differences between copays and high deductible health plans. Who would a high deductible health plan actually be best for?
So in the spirit of brevity, I'm going to give answers that could require a lot more detail. But the spirit of a high deductible health plan is simply a person that's more in the mindset of stewardship, and maybe we'll call it betting on themselves. So if we're going to go real simplistic, usually a low utilizer of healthcare expenses, and then ironically, folks with really high utilization of healthcare needs are the two pockets of folks that are most attracted to a high deductible health plan. And in the middle between that is groups that would be more potentially attracted towards a co-payment style plan. So if you picture somebody that might have very little large claim necessity, but maybe they're on 3 or 4 medications. So it really helps them in their monthly budget to have a fixed co-payment for their medications. And even though the pricing might be a little bit higher in premium, the stabilization of their monthly control cost to co-payments for their drugs can really help them. That doesn't mean a high deductible health plan wouldn't work there. This is really more about their personal finances and ability to steward their way through their costs on a routine monthly basis. So that's how I'd answer that without going too much deeper.
Awesome. Okay, somebody else asked, I'd like to hear if insurance would be cheaper going through Employer Flexible or direct with Blue Cross Blue Shield.
I think it's a wise question. And I think there's something inside of the story today that probably alluded to that. So the answer would be, are you as a buyer potentially a company full of folks that are of lower risk as far as the health issues that one has or the collective whole has? Or are there a lot of health issues inside of your small company, right? And if there's a lot of health issues that are adverse, that are causing a lot of claims issues, then the community rated pool directly to Blue Cross would certainly work in your favor during this season of time. And if you're blessed to have an audience of buyers that are a little bit less on the average risky than the community average rate pool, and that can be compared just through quoting, right? Then the large group pool will definitely be to your advantage. So it's a matter of risk assessment is what it comes down to.
Awesome. This is a good question and one you may be able to answer a little of. What is the outlook for insurance costs in 2025? Do you have a crystal ball?
Wow. So medical inflation is the only way to give anybody somewhat of an answer on this. So the rising cost to pay healthcare providers and pay healthcare claims, which includes the positive medical inflation tenets that I spoke to, are affecting every pool. So when somebody asks, what is it year over year or last year versus this year, which really takes us to now, not 10 years ago, medical inflation this year is hovering, depending on what pool you're in and what city and what state, but nationwide hovering between 7 and 10%. So all pools are going to be laying that in to the variables, the 3 variables related to how your insurance renewal will be put in front of you. And if you're in a non-experience rated pool, that means you're in a community pool, your inflation plus the change in your age and zip codes will be the only 2 factors figured into your renewal. If you're in an experience or an underwritten pool, right, then it's your age and zip code factors, the medical inflation impact of the pool evenly distributed to you, and the adjustments of your experience, right? So if you've gotten less risky because some risk left your group, you could get an offset against your other factors. If you got more risky, then that would be tacked on top. So if you want just a core baseline, that 7 to 10% inflation factor is built in, and then how the other factors unique to you will play out would be unique to how your company changed from a year ago.
Great. Thank you so much. A question that came in from our group here on the webinar, what percentage of insuring pricing should we expect year over year? So less about 2025 and more just kind of from a general standpoint, what do you typically see year to year for?
Yeah, so this is where I always tell people to remove themselves from using the word insurance and what is happening with medical cost. And insurance pools have to mirror the rising cost of medical care. So again, that sounds like a redundant answer to the last couple. But if the cost of healthcare has gone up 7 to 10%, the insurance pricing has to go along with it. The people that don't experience those type of increases are because they got younger because of the turnover in their population, or they're in a pool that has experience rating and you got younger, or less risky because risk departed from your group, or a combination of the both. And it was enough to offset and reduce or offset the inflation factor that is absolutely part of the equation. It's that simple.
Great. Okay, I wish we had, all the time in the world to keep asking you questions. We do have quite a few more that came in beforehand and then also now in the webinar. So Brittany and I will make sure that that gets over to Erin for answering and then gets out to you all so that your questions are all answered. But I want to thank everybody so much for their time on this webinar. Thank you to Erin for walking us through. And we hope that we see you all at our next webinar in Q1.
Thanks,
Thank you.
Al. And did anybody fall asleep? We can't tell. We can't see you. Okay, so I'm going to go with no one fell asleep. That was riveting. All right, just kidding. Thanks, y'all. Have a good day.
Thanks. Bye-bye.
You.